Everyone, this is Adam again, and today we're going to be going over Unit 7, which will be designing treatment regimens. The objectives today include going over our process for how we come up with a rational approach for medication prescribing, making sure that we're using the appropriate medications and the right amounts and the right timing and factors like that. We'll also look at a couple other subjects, including the necessary information for valid prescriptions. And some ways that we can help to mitigate prescription errors. So when you guys write medication orders, it'll be that the correct information is being communicated to make sure the patient gets the correct medication, the correct timing, correct amount, and all that good stuff. And then finally, we'll talk a little bit about discussing controlled substances and some of the regulatory management. When we're following this method of rational prescribing, first you have to start off with a diagnosis, and then once you're at that point, you can kind of decide what your next steps are going to be, including whether it be surgery, counseling, maybe no therapy whatsoever. But in a lot of cases, we're going to see that medications are going to be utilized for many disease states, and a lot of these are going to require prescriptions. So it's really important to understand this approach, and we'll talk a lot about this idea of rational prescribing when we get into pharmacology 1 and 2, especially as we discuss more and more about individual disease states. We know this is really common. We know that a lot of times patients, when they come in for a visit, we know that they are expecting medications or a prescription most times, and a lot of times this is the case where they estimate that around 67%, about 2/3 of office visits, usually ends up in it with a prescription being written. Usually an average about one prescription, but it could be more depending on whatever the disease state happens to be. And so we need to really follow this rational approach to make sure that when they do get that prescription, that one, it's valid, the reason why they're getting that prescription makes sense, and that it's going to be appropriate for that patient. So the first step for rational prescribing is, again, to make your specific diagnosis. A lot of times patients come in, they want the provider to do something for them, right? So in a lot of cases, they want a prescription. It's pretty easy on you guys. You just write a prescription, it's on a piece of paper, they're good to go. Patients leave pretty satisfied. But you'll see that there's a lot of unwanted consequences that come along with this. Writing prescriptions just to satisfy patients. You see things like unnecessary cost to the patient. You end up seeing a lot of things like antimicrobial resistance. This is a really big issue, especially with use of broad spectrum antibiotics being used to treat viral infections. This is huge. So this is where we see a lot of resistance to things like fluoroquinolone antibiotics, leading them to be much less effective because you end up selecting out for resistant strains when you are applying antibiotics in viral infections. And then also you run the risk of having things like adverse drug reactions or drug interactions can start to pop up. And so in a lot of cases, you may end up leaving your patient in a worse state than when they actually started with. So for an example of step 1, let's say you have a patient with probable rheumatoid arthritis. Again, sometimes these things are tentative diagnoses. You may not have confirmatory lab results or anything like that, but you kind of have a good idea that this is what I think it is. Let's go with this. So again, when you're making this diagnosis, obviously your reasoning and whatnot should be shared with the patient, so make sure everyone's kind of on the same page. So this would be step 1 for coming up with a drug treatment regimen. So you have your tentative diagnosis. The next step is to kind of start to consider the pathophysiology behind that diagnosis. By having a good idea of the pathophysiology and knowing the pathways of the disease state, it gives you better insight in what types of medications, what type of therapy you're going to be offering to the patient. So for instance, with rheumatoid arthritis, we know that the issue is, it's an autoimmune disorder. We know there's a lot of inflammatory mediators that are involved in a lot of the symptoms that come up in RA. And so for these patients, that something like a non-steroidal anti-inflammatory, something like ibuprofen or naproxen, can be used to treat rheumatoid arthritis, right? You wouldn't necessarily use something like acetaminophen or Tylenol because you know that pathway, the way that drug works, doesn't really help to affect these inflammatory mediators, so it's not going to be as effective, right? So then, obviously, you should provide the patient with the appropriate level and amounts of information depending on, kind of where they're at, education-wise or age-wise, and tell them why you're treating a specific disease state the way you are. So say, for instance, you have someone who is coming in with an upper respiratory tract infection. They say, oh, I need an antibiotic. you can say, well, actually, we think this to be viral, and so because of that, we know the antibiotics are not going to be effective, right? So lots of different examples you could use this with. And again, lots of great resources online you can use to help convey this information to your patients. Next, you really need to select the objective of your therapies and come up with an objective for each disease state process that we kind of identified previously. So in the example of rheumatoid arthritis, we kind of come up with two goals. First one to be relieving the pain by reducing the amount of inflammatory mediators are being generated and just kind of dampening that whole process in general. That's going to help to deal with a lot of the symptoms the patients are symptoms of pain the patient's experiencing. And the next goal would be to help to arrest the course of the disease state in order to prevent it from developing further or becoming worse over time. So again, because this is a different goal, you have to consider different types of medications potentially in order to help achieve that goal. In some cases, you may be able to get kind of double duty out of one medication, but in something like this with RA, you'd actually have two different medications you might be using, or two different types of medications in order to deal with this process. So next, you would select your drug of choice. And so again, we may need one or more drug groups to be represented here in order to help reach our therapeutic goals that we identified in the previous step. So again, we really need to take patient specifics into account when we're deciding what our drug of choice is going to be. Because again, people are all different, so one medication might be really good for one patient, but maybe a disaster in another patient. You have to look at things like the age of the patient, look at their other concomitant disease states, look at other medications they're taking. Like, look at all these factors in order to come up with what's going to be best for your particular patient. So for instance, with our RA patient, we have to look at things like, okay, well, does the patient have a history of aspirin intolerance or perhaps things like GI ulcers? This could be worsened by anti-inflammatory drugs, especially can lead to things like GI bleeds and whatnot, especially over time due to the fact that these NSAIDs they end up affecting the kind of the protective barrier on the stomach, and so you may find some patients who respond better to one agent versus another, but it's good to have an idea of what the history is. Also look at things like, okay, is cost going to be a major issue for your patient? Do they have insurance? Can they afford these different medications? Especially with rheumatoid arthritis, you're going to see that there are certain drugs that are very kind of old school drugs that are relatively cheap you can use, but then there's going to be other ones which may be more effective that are going to be much, much more expensive. So, especially a lot of the biological products that are protein based, they can be very, very expensive, and so it may be leading you to try one therapy versus another depending on with the patient's ability to actually acquire the medication. And look at things like, okay, is once daily dosing important? Are they able to keep up with a regimen that may need more frequent dosing or not? So it may be better for your patient to have something where they can just take it once a day. Maybe they have memory impairment. It may make it a little bit more, a little less complicated for them. But these are all things you should consider, and which would lead you to choose one drug versus another. Next step, you have your drugs picked out. Now you want to determine the appropriate dosing regimen for that patient. A lot of this is going to be determined by the pharmacokinetics of the drug itself. So keeping in mind things like organ impairment, if the patient has renal disease, that may lead you to change how often you may dose the medication or what type of dose you may use. So instead of taking it, say, once daily, you may take it every other day. And then also, what will the patient actually tolerate? So again, how many times a day are they willing to take it? Do they have, especially older patients, do they have the ability to have kind of aids to kind of help them make sure they get the medications appropriate, whether it be a person or a memory aid or anything like that. But that will all lead you to determine what your best approach as far as the dosing regimen is going to be. The next step is going to be devising a plan for monitoring the drug's action and trying to determine what your endpoint of therapy is going to be. We know that some medications may be treated, and you may be using them for a patient's lifetime. Some medications are going to be more for short courses. And so you need to find a way to figure out what that endpoint is going to be, and then also how you're going to be monitoring the drug's actions up until that point. So you really need to describe to the patient the drug effects to monitor for. So what type of side effects you're going to be looking for, when you should expect to see relief of pain, things like that. And then also any kind of pertinent laboratory testing that may go along with that. So for instance, for patients with depression, if I were to prescribe someone a selective serotonin reuptake inhibitor to them, and they expect to have immediate relief of their depression the first time they take the medication, they're going to be pretty disappointed, right? You need to explain to them, okay, this drug takes 6 weeks for it to work, and so we need to have kind of a prolonged trial period before we can say whether or not this medication is effective or not, or we need to try something else. Looking at things like warfarin. It's an anticoagulant, and you titrate your dose based on the patient's INR in order to achieve a specific range. And so for that, you need to let the patient know that, hey, we need to check you a couple times a week until we get you stabilized out, and then you can start to space out how often you get their INRs. And so it needs to be really clear to the patient, because otherwise they may not be really willing to buy in to the plan if they're not willing to keep up with things like frequent visits, or if they're expecting different things from the medication. So again, explain the rationale for the prescribed duration of use is really important as well. So things like making sure patients take the full course of the medication as they're supposed to. So things like antibiotics. You'll find a lot of patients who will just take the medication until they start to feel better, and then they'll stop it prematurely. And so the next time they start to get an infection, or what they think is an infection, they'll just start to take the rest of their antibiotics from before. Really not appropriate, because again, they may have a different strain of bacteria. They may just have a viral infection. And then the other thing is, if they stop taking the course of antibiotics too soon, especially if it was a true blue bacterial infection, that can lead to reemergence of the disease as the bacteria start to repopulate, and can lead to more resistant strains. So again, the rationale for the prescribed duration of use is really important for them to understand as well. And then also, what might constitute a change in therapy. So again, if you have a patient who is taking a non-steroidal anti-inflammatory drug, and all of a sudden they start to have dark tarry stool, that would be really kind of a big warning sign, right? So that should be something that should prompt them to either come to the emergency department or give you a call, which would lead to changing of that medication. So let them know the warning signs, let them know the really important things that they need to be aware of, so that they can either come back in or stop taking the medication, or whatever it happens to be. So now you've selected your medications, you've got your dosing regimen figured out. The next thing to do is going to be planning a program for patient education. Again, all patients are going to be different, so you want to find some way to be able to educate based on your specific patient. So whether it be a language barrier, which can be fairly common here, especially here in Florida, especially here in Orlando. So we have a large Hispanic population, so being able to speak Spanish or have Spanish materials, educational materials available is very handy. And also being in Orlando as a travel hub, you oftentimes have patients from lots of different countries coming in, and you may need to communicate with. I had someone just the other day come into the outpatient pharmacy, and they were picking up a prescription for an anti-epileptic for their child. And so, this is a new diagnosis. There's a lot of education that needs to go into that. But, she was from an Asian country. Couldn't quite figure out where it was from, but we simply could not communicate, because there's really no, just the language barrier is too much there. So oftentimes you have tools that can help you with that. So for instance, at the hospital we have these interpretive services. They come up on iPads. You basically kind of roll into the room and select your language. You can have that better conversation to get that information across. You can also have educational barriers as well. Could be your patient's very young or very old, and so you may need to simplify the information a whole lot, or in some cases you may need to be able to provide information to, say, caregivers or whatever it happens to be. Utilize educational materials whenever possible, especially in certain cases of medications, especially if they have kind of unique delivery devices. You want to make sure that the patients or the caregivers know how to use that device before it's actually needed. Because again, for an example, Diastat, which is a brand name for diazepam, is a rectally administered medication to use to break seizures. So again, if your child's having a seizure and you've never used this device before, that can be very it can induce panic in a lot of patients, or a lot of people. So because of that, you want to make sure that they're educated beforehand. They have videos you can watch, they have handouts you can take. Same thing goes for devices like EpiPens. So if you're having an anaphylactic reaction, you probably want to know how to administer the EpiPen beforehand. So there can be training devices and things like that that can kind of help you out to practice before you actually need it. And then pharmacies do provide drug information, and certainly pharmacists are good sources for counseling, but don't always assume that they're going to explain it to the patient. Especially in a lot of really busy stores, you may have pharmacists that are just far too busy to really sit down and talk with the patient for the same amount of time that you might have the opportunity to. And again, even if they hear it twice, it's probably not going to hurt. So again, make sure that you're willing to provide that information to them because they may not get it otherwise. So as another kind of soup to nuts example of rational prescribing, let's say we have a 3-year-old patient who's presenting to our clinic with left ear pain. He's got a fever of 101.3. He's got cough and runny nose. You go ahead and look inside the ear, and this is what you see. So obviously you're going to start off by making your tentative diagnosis. Based on that, we're going to be thinking that this is acute otitis media. And so at this point now, we need to explain the diagnosis to the patient and the family, and we need to think about what type of etiology we're going to be dealing with and be able to explain that to them. So whether or not that we think this to be likely bacterial in nature versus if it's more viral, obviously we're going to be thinking much more on the bacterial side for this type of infection. So once we've made that tentative diagnosis, we need to consider the pathophysiologic implications of the diagnosis. So again, look at things like what are the most common bacteria that can cause acute otitis media. Because if we think it's going to be one type of bacteria, that's going to lead us to use one type of antibiotic versus another. Or if we think it's more likely to be viral, it may lead us to use something completely different or nothing at all. So again, in this case, acute otitis media, we see a lot of strep pneumo and a lot of H. influenza that are the most common bacterial sources of acute otitis media. And so that's going to help us to tailor what type of antibiotics we're going to use. It helps us to narrow the spectrum, so that way we're not using something that is, can treat every type of bacterial infection. We want to use something as specific as possible, because that helps to narrow down the amount of resistance that we can potentially develop. So again, once we have this idea of what we think it's going to be, we can provide that information to the parents of the family, let them know, okay, most likely it's going to be one of these 2 bacteria. This is why I decided to go ahead and use an antibiotic that is most likely going to be able to treat those bacteria. Again, lots of information out there, especially on things like the internet, that are very useful for conveying a lot of this information. So things like the CDC has a lot of good information on things like when to use antibiotics, and hopefully to educate patients and families so that they have a better idea of why you're doing what you're doing, and when you may not give them a prescription, that they're okay with that. Right. Again, here you can see that the Spanish version is available as well. So lots of resources out there. Again, usually just one Google search away. So now we need to select our therapeutic objective. Obviously, the 2 main goals here are going to be 1, to eradicate the bacterial infection. So in order to do that, we're going to be using appropriate antibacterial coverage. So we're not making sure that we're not going to be using something that might treat tuberculosis or something that will treat a viral infection. We want to make sure we're selecting something that is tailored for strep pneumo and H. influenza. And then 2, we would like to treat the sequelae of the disease. So we want to do things like manage the inflammatory response. So patients got a fever, let's give them something like an antipyretic. So now you can already see we're up to 2 different medications we could potentially be using for treating this acute otitis media. Next, we'll try to figure out what our drug of choice is going to be. So again, we're taking patient specifics into account. So we need to look at age, organ function, allergies, and then previous and current medications that they're already taking. You want to look at things like, have they had previous courses of antibiotics for similar complaints? Because they may lead you to select a different type of medication. If they've had lots of previous courses of antibiotics, that means they're more likely to be harboring kind of resistant bacteria. And so you may need to use a stronger antibiotic versus something that's more kind of general purpose. So again, use your resources to find what the appropriate medications are going to be in those situations. Best way to do this would be to look at your drug references for one. So you have things like LexiComp, Micromedics, Clinical Pharmacology. These are all resources that are available. Most of them have digital versions either on your phone or on the computer. Usually wherever you're working will have their drug reference of choice available to you while you're working. Otherwise, individual subscriptions could be pretty pricey. But in this case, if we're looking for infectious disease knowledge specifically, you can use things like the Sanford Guide, or we can look at the Red Book. Redbook is specifically an antibiotic guide for pediatric patients. And you can use these guides to say, okay, I've got my diagnosis. What do I think are the most likely pathogens? What are the most likely antibiotics going to be to cover this? Give you dosing. It'll give you first-line agents, second-line, third-line agents that are going to be, maybe the first-line agent is going to be appropriate for your patient because say they have an allergy to that drug. Well, now you got to look to see what your second or third-line agent is in order to treat that infection. And then also, clinical practice guidelines are super useful for this as well. So looking at things like the IDSA, Infectious Disease Society of America, has guidelines for lots of different disease states. Very, very useful for figuring out what your appropriate drugs regimen is going to be. And then also American Academy of Pediatrics might be another source since you're dealing with a 3-year-old patient. So, looking at drug selection consideration, okay, how often do we have to give the drug? If you have a really angry 3-year-old because they have a fever and they're sick, trying to give them medication that may or may not taste good, 2, 3, 4 times a day could be a little bit difficult. So maybe you want something that you can give less often. Look at things like what dosage forms are available. Obviously, being a pediatric patient, taking tablets might be very difficult for him or her. So you need to see, are there liquid preparations available for them? Maybe there's drug shortages making it impossible to use your preferred drug. Maybe you need to find out what an alternative could be. And then look at things like how much does it cost? Does the patient have insurance that can cover it? Is it available anywhere under certain free antibiotic options? Things like Publix or things like Walmart, what may have reduced cost or free medications depending on what their plans are. And then finally, how palatable is the medication? So you'll find that kids obviously do not want to take medications that taste really bad. So a lot of things either come grape flavored or cherry flavored or bubblegum flavored. So figure out if it's palatable for the patient. And then in some cases you may have resources like devices which can flavor the medications further. So a lot of pharmacies can provide that service where they may make it taste like watermelon or mocha or whatever they want it to taste like, just to make it a little bit more easy to get it into your patient. So here's an example of a table taken from the IDSA guidelines for acute otitis media. And you can see here they have it broken down into kind of specific situations and what the drugs of choice are going to be, or potentially what alternatives you can use. So here you can see it's broken down into, okay, we're doing either immediate initial treatment or delayed antibiotic treatment. And then we also have it if the treatment failure occurs after 2 to 3 days of initial antibiotic treatment. If that fails, what do you go to next, right? So you look here under your first line recommended treatment. You can see it's amoxicillin. You can use between 80 to 90 milligrams per kilogram per day in 2 divided doses. So there we already know we're going to be using twice a day dosing. And so that's our first line. That's what you should go with most of the time. Well, what happens if you have a patient who has, say, something like a penicillin allergy? Well, then you might need to utilize an alternative, something like ceftonir, which is cephalosporin. Here you can see you'd use ceftonir 14 mg per kilo per day in either 1 or 2 divided doses. So say, for instance, you couldn't really give your patient, say twice daily dosing. This might be a better alternative since you can only give one-time daily dosing. But on the alternative, ceftonir is a little bit more broad spectrum kind of antibiotic. You're more likely to see resistance if it's used inappropriately over time. So that may not be a good idea from that standpoint, which is why most of the time you're going to end up going with amoxicillin. You can even see as another alternative down at the bottom, you have ceftriaxone. This is normally either given either IM or IV, and so that one you give once per day for 1 or 3 days. And so that would be a situation where if you had a patient who, say, could not take anything orally for whatever reason, and you need to give a parenteral agent, that would be your alternative right there. So again, you just kind of go through and figure out, okay, where's my patient fit into this algorithm, and go from there. And then if you have treatment failure, then obviously you would say, okay, well, that amoxicillin didn't work. Let's step up our game a little bit. Let's try to use something that's going to be able to get some of those more resistant bugs. And so you might utilize a combination product here like amoxicillin clavulanate, which is clavulanate is a beta-lactamase inhibitor, which allows the amoxicillin to work on more resistant bugs. And so that would be kind of your next step up in therapy if the initial amoxicillin failed. Right, so you just kind of go on a stepwise approach, figure out what your preferred treatment is, and then go down from there based on patient specifics. So again, in this situation, your patient did not have any contraindications to receiving amoxicillin, so you decide you're going to use amoxicillin suspension, because again, it's a 3-year-old, so tablets probably wouldn't be too palatable to them. And we do 90 milligrams per kilogram per day, divided twice a day. And we know that our suspension comes as a 400 milligram per 5 ml concentration. And the patient weighs 20 kilograms. So then the next question is, well, how many mLs do you need per dose? Because again, if you tell the patient's mom, hey, I want you to give 90 mg per kilo per day, divided twice a day, they're going to look at you like you have 3 heads, right? So you need to figure out, okay, how many mLs do they need to give per dose? So again, we're giving 90 mg per kilo per day divided twice a day. Our suspension is 400 milligrams per 5 mLs. That's a pretty common way you'll see a lot of concentrations being described on medication bottles. And the patient weighs 20 kilos. So again, how many mLs do they need per dose? Pretty easy math. All you got to do is calculate it out. So we know that we're going to be using, since it's 90 mg per kilo per day, twice daily, we know that each dose will be 45 milligrams per kilo per dose. So we'll do 45 times 20 kilograms. So we know you should be receiving roughly 900 milligrams per dose. We know that our concentration of our drug is 400 milligrams per 5 mLs, which would equal 80 milligrams per ml. So if you divide that out, so 900 milligrams per dose divided by 80 milligrams per ml comes out to be 11.25 mLs. So again, that's what your instructions would be to the family. Hey, you're going to be giving 11.25 mLs. Oftentimes they're going to be having a dosing syringe so they can get the proper amount of medication to the patient, and so that would be your treatment regimen. Next, we're going to be trying to figure out what the monitoring plan is going to be, and then also determining what our endpoint for therapy is going to be. So again, we should be able to describe to the patient the drug effects, things we should be looking for. So again, how can you tell if it's being effective? Okay, well, after 2 or 3 days, you should start to see symptoms start to resolve. Maybe fever will go down, ear will be less painful, less fussiness, things like that. And then also adverse effects. So know that if the patient gets diarrhea, this may not be necessarily due to the disease state, but could be due to the antibiotics. And whether or not that should be something you should really be worried about, whether it's something you should cause immediate discontinuation of therapy, things like that. Again, explain the rationale for the prescribed duration of use. With this one, again, you're going to be treating for a prescribed number of days, which the guidelines will provide for you, and then you want to make sure the patient takes that full course. So even if they're feeling better after 2 or 3 days, make sure they're really taking for the full prescribed, 10 to 14 days, whatever happened the drug you selected was happens to be, so that way you don't have recurrence of disease later on. And then again, what would explain what would be constitute a change in therapy. So if they have a severe allergic reaction, the failure to improve after 2 or 3 days, those would be things they need to know to either call up or come back in order to get a different type of therapy initiated. Next, we want to plan our program for patient education. So we'll find a way to educate specific to our patient, both to, say, the parent and also the patient if possible. So again, look at things like language barriers. Maybe they don't have English as their first language, educational barriers, and then obviously utilize our education materials, whatever they're available. So a lot of places will have kind of automatic printouts that will have a lot of the information, like why we're treating this, why we think it's a bacteria, how long to treat for, things like that, so that way they can take it home with them and be able to read that and educate themselves. So medication errors is a huge topic, and one of the things I want to focus on here specifically is just going to be on prescribing errors. So some of the things that you guys can do as the providers ordering medications to mitigate some of these pitfalls and try to prevent some of these med errors from occurring in the first place. And so again, because you guys are kind of the start of the chain, it's good to focus on this, and in some ways we can try to prevent these. Now, all prescriptions really need to be legible and unambiguous. The legible part has gotten better, especially as more systems go to be more fully computerized. Just the other day, we had a downtime in which case, instead of the printer obviously printing out prescriptions, the physicians had to handwrite them. And I had one very young doc who said, I was like, well, how do I write a prescription? I've never had to write one before. So you guys may never come across that, who knows, but just in case, we'll talk about some of these things, at least on the writing side, that can help. And the other thing is really they need to have enough information so that anyone can kind of figure out what your thought process was or what you're trying to do. So that way they can discover possible errors. It goes from nursing to you know, families, patients, pharmacists. We all need to have an idea of what the heck you're thinking. Because I can't tell you how many orders I've gotten on the inpatient side, and keep in mind it's a fully computerized system where I go, what were they thinking? And I have to call to get clarification. So the less phone calls you get, probably the better it's going to be. So we'll talk about some things we can do to help prevent that. So as far as requirements for a prescription, here's some of the Florida statutes and some of the things that are necessary to have on there for it to be a valid prescription. Again, this may change a little bit from state to state, and you'll see different regulations based on things like what type of, if it's Medicaid, it's paying for, and things like that. But in general, this is the stuff that needs to be on the prescription. So again, name of the prescribing practitioner, name and strength of the prescribed drug, the quantity that we're going to be prescribing, and then clear directions for use. Should be dated and then also have a signature, whether it be electronic or handwritten. You can see here in this example, we have an order for divalproex or Depakote, would be the brand name there. Notice how there's no abbreviations or no kind of shorthand for what they want. They said, okay, they want it by mouth 3 times a day. They're not using things like PO or TID. So that way it makes it, again, more clear. So again, a lot of prescribing errors happen due to kind of missing information. So that's why it's really important to always keep these as clear and as full of all the necessary details as possible. So things like resume pre-op meds isn't a problem. You can have issues where you may have thought that you wanted to continue every single medication beforehand, but due to, say, something that happened during the procedure or, say, change in patient status, it may not be appropriate anymore. So if you just say resume pre-op meds, that may not be appropriate. And so a lot of cases this is not done anymore. Usually you have to do medication reconciliations every time you have a change of a phase of care for the patient. That's led to a lot less prescribing errors from that standpoint. Things like continued present IV fluids can be problematic, especially if someone incorrectly remembered what the rate was before and inputs it incorrectly into whatever IV pump they may be using. Things like that. So it's really important that all your prescriptions need to be really specific. Other errors that can happen include things like failing to discontinue a prior medication when starting a new one. So say, for instance, you have a patient who is post-operation and they were on IV opioid analgesics for pain, and you're trying to transition them over to oral pain medication so that way they can go home. Well, if you don't read that whole medication profile and forget to discontinue the IV therapy, they end up getting oral and IV at the same time, which may not be appropriate for that patient. May lead them to get too much medication, become sedated, and things like that. Also, incorrect orders may not indicate short versus long-acting dosage forms. So it can be really problematic, especially if you have patients who are not getting prescribed therapy, for the appropriate amount of time. So if the medication kind of wears off too early, that can be problematic when you meant to have the long-acting form on board. And then also having as-needed orders or PRN orders without indications for what constitutes a need, right? So I can just say, ibuprofen as needed, but for what, right? So you need to be very specific about that so that way, just because you have a change of shift and different nurses are coming on, they don't interpret that order differently, right? You want to really leave it so that none of your orders are up for interpretation. It should be really as black and white as possible. So in this case, you may say ibuprofen as needed for minor pain or mild pain, whereas you may have an additional order, say something like morphine, as needed for severe pain. And then at that point you go, well, what is severe pain versus mild pain? And so you get different pain scales and things like that. But it's good to be very specific and make sure that wherever you're working, everyone's on the same page for what those mean. And make sure the patient understands what that means as well, so that way they don't take the medication inappropriately. If you're having to handwrite a prescription, obviously poor handwriting can be a really big problem. Imagine trying to read this prescription and try to figure out anything from it. I can barely figure out anything from just reading this. But again, a lot of this is being supplanted by e-prescribing. So hopefully, some of you guys may never need to do this, but just in case, make sure everything is as legible as possible. Some other examples of prescribing errors to avoid would include things like misplaced decimals. So having 0.1 being misread as 1 could mean a tenfold overdose for a patient. So again, you always want to precede decimals with a 0. And then having unnecessary zeros after the decimal. So having 1.0 may be misread as 10. So again, if there's nothing after the decimal, don't write anything there. So again, you should just leave it as just 1. And then also other things like misreading U as a 0. So if you had things like 10 U of insulin, could be misread as 100 units of insulin instead of 10. Again, tenfold overdoses are never a good thing to have for your patients. And so always write out the word units. So again, you'll hear a lot about unapproved abbreviations should really be avoided, and U is going to be one of them. Here we have microgram being represented here. Really could be misread in some cases as milligram, which could be a 1,000-fold overdose. So again, use MCG as a way to abbreviate microgram, less likely to be confused in that case. Lots of problems of QD being used and being misread instead of using the word daily. So QD could be potentially mixed up with QID, which means they'll be getting medication 4 times a day instead of 1. So we always recommend writing out the word daily. And then some other ones that don't come up quite so often, but using unapproved abbreviations for medications. So back in the day, they used to write out morphine sulfate as MSO4, which could be confused with magnesium sulfate or MgSO4. So lots of issues where if one of those got mixed in for the other, could really be deleterious to the patient. Other things that should be avoided include take as directed. Generally should be avoided. You really want to have more specific instructions whenever possible. Some exceptions to that may be if the packaging provides pretty discrete information on how to take it. So this would be an example of a methylprednisolone dose pack. It's a steroid taper, where it tells you on the first day you're going to be taking, these 6 pills, how to take them, and then you gradually titrate down to take 1. That would be appropriate, but in most cases, if you can, just write out specifically what you're going to be administering to the patient. Because again, in this case, if the pharmacy you were sending the patient to did not have this kind of dose pack, they just might get so many pills inside of a bottle and may not know how to actually take that. So really need to be specific with how they should be taking their medications. Other things that can happen, especially with verbal orders being potentially problematic, if you have drugs with different dosage forms, can be a problem. So imagine you're in a busy ED and a patient comes in coding and you want to give them calcium. We can say, okay, we'll give them an amp of calcium. Well, looking at this, you can see calcium chloride or calcium gluconate, and both are pretty readily available, especially in code trays and things like that. And if you look, both of them are 10%. Both of them are 100 milligrams per ml. Both are coming in a 1 gram vial, 10 mLs. So the problem here is the calcium content between these two are not the same. And in fact, if I were to give 1 vial of calcium chloride, that would be about 3 times the elemental calcium is in the calcium gluconate. So just saying calcium really isn't good enough. You need to say, okay, give them 1 vial, give them 10 mLs of calcium chloride or gluconate in order to be specific, and make sure the patient gets the right medication. Another example would be give them an amp of bicarb. So sodium bicarbonate frequently comes in 2 different concentrations. One's at 8.4%, which is 1 milliequivalent per ml. The other one is the infant formulation, which is 4.2%, or 0.5 milliequivalents per ml. You might imagine that if I were to say give them an amp of bicarb, notice these two have different sizes. The 8.4% comes in the 50 ml, the 4.2% comes in the 10 ml. So if I say give an amp of bicarb, we need to be specific and say, okay, give them 50 mLs of the 8.4% sodium bicarbonate, or give them 50 milliequivalents of sodium bicarbonate. That way the correct dose is being administered. And because that way if you get the wrong one mixed up, imagine giving 50 mLs of sodium bicarb to an infant you didn't mean to, could be problematic in some cases. And then not being specific with your units can be a big problem as well. So start the patient on 20 of dopamine. Okay, well, what does that mean? Does that mean milligrams per hour, mics per kilo per hour, mics per kilo per minute, micrograms per minute? What should that really be? I've seen cases where nitroglycerin was run incorrectly. An entire bottle was infused into a patient within, say, 20 minutes because it was going at mics per kilo per minute instead of micrograms per minute. right? So don't take it for granted that everyone knows what you're talking about, because really none of us are going to be psychic. You need to be specific and say, start the patient on 20 micrograms per kilogram per minute of dopamine. Other problems can come from inappropriate drug prescriptions. So whenever prescribing a new medication, it's important to remember what potential contraindications or interactions may come up with. Other medications the patient's taking, thinking about over-the-counter and herbal things. Really important just to have a full medication list in general to make a more educated decision. Some cases there may be things like physiochemical incompatibilities between drugs. So certainly certain IV medications when mixed together can precipitate, can either lead to a line being occluded, lead to big issues, or potentially an embolus getting into the patient. And then also look at things like disease state interactions as well. So whether or not say a medication may aggravate another disease state, say may make hypoglycemia more prevalent, or things like that, just so you can make sure that the patient's not developing any other sequelae of their disease states due to this interacting medication. The next thing I want to talk about is going to be compliance, otherwise known as adherence, and this is going to be how well your patient's actually following your treatment instructions. And so we know that all patients do not take medications as they're supposed to 100% of the time, and it really falls down into 4 different types of noncompliance. So one, the patient fails to obtain the medication. Patient fails to take medication as prescribed. Patient prematurely discontinues the medication, or the patient is taking the medication inappropriately. So we'll talk more about these individual ones in just a second. So patient fails to obtain the medication. They actually look at the numbers. About a third of patients never actually have their prescriptions filled. A lot of that has to do with cost. In most cases, especially if the patients are uninsured, had issues to where patients maybe get prescribed something like an antibiotic and a pain medication and may only be able to afford one of them. And some patients may go with just getting the pain medication because that's really the more pertinent thing to them right there when they're in pain. You have issues with difficulty in finding the product, so drug shortages are a very real thing, and we're into drug shortages all the time, especially on the inpatient side. If you're prescribing a specific compounded product that's not commercially available, then you need to find a specialty compounding pharmacy to actually have them filled, which can be problematic. And then also look at the time of day. Obviously, prescribing a medication at 3 o'clock in the morning at a busy ER, where can they find a pharmacy that's open to actually fill that? So you may need to have a list of things like 24-hour pharmacies that are around in order to help make sure the patients are actually filling what they need to get. And then also just in general, patients may have a lack of perception of the need for the medication. So they get the prescription and say, well, I don't really think so. I think he's got the diagnosis wrong. I'm not going to take that. That could be another reason for non-compliance. Patients may fail to take the medication as prescribed, and this can fall into a range of categories. So it could be the wrong doses that they're taking, wrong frequency, wrong route, wrong technique of administration, or due to inadequate communication or understanding of the instructions. So for instance, if you were to tell someone, take 2 tablets by mouth twice daily, what does that mean to the patient? Do they actually understand what that means? Do they say take 2 tablets in the morning and 2 tablets at night, or should they take 1 tablet in the morning and 1 tablet at night to be 2 tablets in total? Depending on their education level or their things like language barriers and things like that, it's very reasonable that they could get mistaken. And so it's important that they you verbalize the fact that they understand the instructions and can kind of explain it back to you to ensure they're actually getting the instructions correctly. You have some patients prematurely discontinuing medications, so if they wrongly assume that a medication is no longer needed, so say they're on an antibiotic and they feel better after 3 days and they don't finish out the full 7 days, that can be problematic. Or if potentially a patient is taking medication and the bottle's empty, the patient must no longer need to take it. I've actually seen people come to that reasoning. And then also if they stop due to a lack of perceived benefit, that can be problematic as well. So for instance, if the patient doesn't feel any different, why should they keep taking it? No one feels their high blood pressure, but if I take a medication to help lower that, they may end up feeling worse because now they have some exercise intolerance. Or if they're taking an antidepressant and they don't feel anything any different for the first 6 weeks, they may feel like the drug's not working and may stop taking it prematurely, may not be telling you about it. Or the patient may not actually understand it's a chronic nature of the disease state. So, for instance, have patients who have bipolar disorder, and so they think, okay, well, I'm going to take this medication, and then once they're not manic anymore, they can stop taking it. But really, they don't realize it's a cyclical disease, and it'll come back later. So again, helping them to understand that the potential duration of therapy that needs to be done, and what to look for in regards to efficacy or toxicities. And then patient who takes the medication inappropriately could be one that is sharing medications with others, especially if they finish up their course of antibiotics in 3 days and they say, okay, well, I got this extra medication and now my cousin's sick, I'm going to give them my antibiotics. Obviously, that could be totally inappropriate. They could be taking someone else's medications, or potentially even medication abuse can be a problem. So especially with certain narcotics, this can be a really big issue. A lot of doctor shopping, pain medication seeking, and so medication abuse can be a real big issue there. Last thing we'll talk about is going to be controlled substances, since we're talking about abuse of medications. Now, the medications become a controlled substance when the DEA feels they have a perceived potential for abuse. And so we have this Controlled Drug Act that requires registration with the DEA. So both dispensers and prescribers all have to register with the DEA. And whenever you're writing a prescription for a controlled substance, the DEA number needs to appear on the prescription, right? And so the drugs, when they get categorized, they fall into one of 5 categories. So Schedule 1, having a very high potential for abuse. But the big difference between this group and Group 2 is that Schedule 1 substances have no accepted medical use, right? Whereas on the other hand, C2s have a high abuse potential, but they do have a current accepted medical use. But the big things here is that dependence, either psychological or physical, is a definite possibility. And then as you go down to C3, 4, and 5, you'll see that the risk for abuse or risk for dependence is going to go down as you go along. And so C5 is kind of like the weakest of the bunch, whereas C2s are going to have the highest abuse potential. So when writing a prescription for a controlled substance, it's important to note that Schedule 2 medications cannot be refilled. They can only be written as kind of a one-time deal, but they can be written for up to a 90-day supply. A lot of medications for attention deficit hyperactivity disorder, a lot of them are amphetamine based and have a high abuse potential, and so most of them are C2s. And so in those cases, if you don't want to have your patient come back for a new prescription every single month, then you could do a 90-day supply potentially, and have them maybe come in 4 times a year for that. They have to be written on tamper resistant security paper, and so it's the kind of paper that if you were to photocopy it, it would say photocopied on it. It's pretty apparent when the paper's been adulterated. And then these cannot be transmitted over the phone. So I can't call in a C2 prescription for, say, morphine or oxycodone. They has to have a paper prescription that the patient would take in. And then your Schedule 3, 4, and 5 can be refilled for a maximum of 5 refills. So you can do basically 6 months at a time for those prescriptions. And they can be called in, and they don't necessarily have to be written on the tamper-resistant paper, but for certain insurances, you'll see that they actually do want those to be written on there. So just to have a quick controlled substance quiz, federally, what schedule do you think these drugs fall under? So morphine. Yep, morphine's a pretty hardcore analgesic. That would fall under a C2 as a very high abuse potential. But remember, it does have an accepted medical use as an analgesic. How about cocaine? Cocaine is also a C2. It might be surprising to some people, but cocaine originally got its use as a medicinal product, and will still sometimes be utilized for things like ENT procedures, because it is a very useful anesthetic, and it also has vasoconstrictive properties, so it's good for ENT surgeries from those standpoint. I personally haven't had to use much in my days from the pharmacy standpoint, but certainly it is still available out there, so that would be a C2. How about methamphetamine? Methamphetamine is also going to be a C2. As I mentioned in the last slide, a lot of the medications that are used for ADHD are amphetamine in nature, or amphetamine derived, and so this does have some accepted medical use as a stimulant agent. And then finally, marijuana. So marijuana is actually still a Schedule 1 substance, which means it has a high abuse potential, which can probably be argued, but according to them, has a high abuse potential, and then also has no accepted medical use. Now, of course, this is federally speaking, and that's kind of the important thing there to note, because we know some states like Washington, Colorado have made recreational use possible, but at any point the government can come down and say, nope, this is still a Schedule 1 substance. These are narcotics. This is a felony to be in possession of it, but they have chosen not to do that. So just keep in mind that kind of local state regulations can be different than what the government says federally, but just know that. Those differences exist and be able to work within that confines there. You'll see that certain medications may have a different schedule depending on the state that you're in. So a good example of this would be carisoprodol. The brand name for that is Soma, and it's a muscle relaxant that is commonly abused, especially in conjunction with other analgesics, other opioids. And so this one is actually a C4 here in Florida, but a lot of other states you'll see that it's not controlled at all. And then just recently, we've had some changes in scheduling of certain medications due to increased abuse. And so tramadol used to be unscheduled, but got changed over to a C4. And then hydrocodone used to be a C3, now has been up to a C2. And hydrocodone used to be one of the most prescribed medications just by volume in the U.S., and now you've actually been seeing big trends in lower prescribing since the change, since there's a lot more tight control on C2s than on C3s. You see a lot of prescribing has gone down because it's not as easy to acquire kind of large amounts like the certain abusers were doing previously. So, any questions, again, please feel free to send them to me, and otherwise I'll talk to you guys next time.